So greetings and welcome. I really want to thank you for taking time out of your busy schedules to have a very brief discussion about the frontline treatment of newly diagnosed advanced ovarian cancer. Things are changing. I want to really have a sort of a practical conversation with you about what has happened here now in 2020. I think the answer to this question is yes. Is it time to change the treatment of newly diagnosed advanced ovarian cancer? My first point is that although ovarian cancer is rare, and I like that, I like it even more that patients are living longer, that the prevalence is 10 times the incidence. And the reason that patients are living longer, no question, is maintenance treatment. I say maintenance treatment because it's a treatment or maintenance, and the answer is yes. But it's after cytotoxic intravenous chemotherapy. I think you're all aware that we have 12 indications in ovarian cancer over the last 5 years. I'm going to talk to you about these two indications on the right. The niraparib maintenance, which you may know as PRIMA, published in the New England Journal in December, FDA approved on April 29th, and then PALA-1, also published in that same issue of the New England Journal and FDA approved as a combination now on May 8th. And I want to sort of distill the data that has recently been presented at the SGO and the ASCO meeting. So 4 of those 12 indications are frontline. The first one was bevacizumab. You're familiar with that. And that was a good start. It never really felt good because there was no biomarker and that the magnitude of the benefit really wasn't exceptional or unprecedented. But we did get FDA approval on June 13th, 2018, based on this study, again, a study I'm very passionate about and a co-author of, in the New England Journal, adding bevacizumab to chemotherapy and chemotherapy and maintenance. You're familiar with this. The time of the duration is 15 months or 22 cycles. The bevacizumab starts on the second cycle so that the patient can heal. And the benefit is 6.2 months with a hazard ratio of 0.62. And that's sort of the minimal threshold for really a broad application. But this only led to an uptake of bevacizumab in frontline somewhere between 40 and 60%. We tried to look at subsets. This is a pre-specified subset in stage 4 patients. There was a 10-month improvement in overall survival in that subset. Again, not a primary endpoint. This is a hypothesis generating, not a hypothesis testing analytical endpoint, so there's no p-value associated with it. But when bevacizumab is added to stage 4 patients, they behave like a stage 3, so there is some value. The adverse events related to bevacizumab in frontline ovarian cancer have been well documented. And the GI events, we really mean GI perforation, and that's higher risk with lots of bowel surgeries and inflammatory bowel disease. This high-risk subset was supported by another hypothesis-generating analysis from ICON-7, so my personal opinion is that it's real. But we're moving now beyond bevacizumab to PARP inhibitors, which inhibit single-stranded DNA repair, leading to double-stranded DNA breaks. And in the setting of impaired homologous recombination, those double-stranded breaks are synthetically lethal. First study after GOG 218 of a PARP inhibitor in frontline was SOLO-1. This was only in BRCA patients, and again, was in December of 2018. This study was exceptional, unprecedented. It was a biomarker-driven study and 2-to-1 randomization. Now with the tablet form, remember we initially had capsules approved, and patients were randomized after response to chemotherapy frontline. If you had a BRCA mutation, either germline or somatic, and here's what you get: a hazard ratio now of 0.30, an improvement in progression-free survival of almost 3 years, a doubling of the progression-free subset at 3 years, and this was exceptional. Problem was, it was only applicable to BRCA patients, which is about a quarter of the patients. It was okay. It was impactful, at least to that quarter. We had always taught that maintenance treatment was supposed to be a holiday, and although there were adverse reactions associated with maintenance olaparib, when those adverse reactions were mitigated, both with supportive care and dose interruptions and reductions, there was no difference in patient-reported outcomes. So indeed, it still is the holiday in this sort of maintenance opportunity. So I don't want you to look at these adverse reactions and say, oh, 77% of patients are on, have nausea for 2 years of the maintenance treatment. No, they had it. And the average time of that nausea was about 2 days. So then we got to PRIMA. PRIMA was a all-comer trial now. This was a very innovative trial, also published in the New England Journal, but a year later now, December 2019, of niraparib. This study did integrate into it as a primary endpoint, a BRCA-like molecular signature, which we call Myriad My Choice HRD or CDX. It's a 3 sort of molecular tests of genomic instability or genomic scarring, loss of heterozygosity, telomeric imbalances, or large state transitions. This is very similar to sort of a BRCA phenotype, so it's beyond BRCA. And this was the primary endpoint of this high-risk PRIMA study, and the primary endpoint is you see here. So if you use niraparib maintenance now, today, after the April 29th FDA approval, you can get a hazard ratio of 0.43, a 57% reduction, and a doubling of the progression-free survival. Again, this is also exceptional in this HRD subset, and it doubles the population. So remember, SOLO-1 was BRCA alone, which is about 25%. This is now HRD, and HRD is 50%. So that's really exciting that we could double the opportunity by using this HRD assay, and this has been an impactful FDA approval that you're probably familiar with. Because it was designed this way, we pivoted, we carried the alpha forward to an intent to treat analysis, and even in the intent to treat analysis, it was a 38% reduction, a hazard ratio of 0.62, incidentally the same hazard ratio of bevacizumab in the ITT population, and again, had a meaningful improvement in progression-free survival. So PARP inhibitors work very well in BRCA and HRD subsets. Again, there were no new safety signals in PRIMA because we had done a similar paper in NOVA published in the New England Journal. Not only did we get an all-comer approval on April 29th, but we also changed the dosing. We thought it was important to personalize the dose where if the patient had a weight of under 170 pounds, or a baseline platelet count of less than 150, we could half the thrombocytopenia and marrow suppression. And there was no difference in efficacy, and you can see the hazard ratios of 0.68, which was similar to 0.62, and 0.39, which was similar to 0.43. So this was transformational in all comers. And again, no difference in patient-reported outcomes. And then on May 8th, just over a week after PRIMA was improved, we synthesized everything together. Bevacizumab plus a PARP inhibitor and the biomarker. Now, this was purely a European study because bevacizumab was more commonly used and got approval before it did in the US. But still, that was a US-like population, which is important. So again, it took newly diagnosed advanced ovarian cancer patients who responded to chemotherapy and were on bevacizumab and added olaparib in the maintenance setting. And again, this was about half of the patients that had HRD. They also treated all comers, but the HRD subset got FDA approval on May 8th. And you can see that that's really where the leverage is, right? The leverage is to start the patient on bevacizumab, do the biomarker, and if the biomarker is positive, then add olaparib in the maintenance setting. And you can see here on the lower left-hand corner that the median progression-free survival in that subset of HRD positive bevacizumab olaparib is 37 months. We did it again. But we did it not only unprecedented in BRCA patients, but unprecedented in HRD positive patients, but you needed bevacizumab in combination to do it. So this really is exceptional, transformational, again, FDA approved and published in the New England Journal. Again, there were no new adverse reactions. Again, I don't want you to look at this and think, oh, all these grade 3 treatment emergent adverse reactions. Remember, supportive care, dose interruptions and dose reductions, and even discontinuations are necessary to ensure that this maintenance treatment time is the holiday, because it's the patient experience, right? We have to help our patients live longer, of course, but also live better. So this is a combination of the bevacizumab and olaparib on the left versus the bevacizumab on the right. Again, no new safety signals. And again, now the fourth time, I didn't show you the GOG 218 patient-reported outcomes, but there was no decrement. So patients and providers should have confidence that they can have a meaningful improvement in progression-free survival without hurting the patient's quality of life. It's so critical. So let's now pivot to some of the newer data. You may have heard about that, although it was just approved on May 8th. There's Chris Grimm from Vienna talked about the surgical subsets, because every patient is not alike. We talked about the molecular sort of opportunity, but also there's a surgical opportunity. And if you look at PALA-1 closely, half of the patients or so had upfront surgery, and then half had neoadjuvant chemotherapy with interval cytoreduction, with the chemotherapy, with the surgery interdigitated between the third and fourth dose of chemotherapy. So you ask yourself, well, what does that mean for my specific patient? And that's what they tried to show. So if you look at this upfront surgical subgroup, you can see that those patients do very well, okay? That there was still a benefit of the addition of olaparib to the bevacizumab. That's important. Here, if you look at the neoadjuvant subset, they don't do as well. I think we all know that neoadjuvant chemotherapy and interval debulking don't do as well, but there still is an improvement in progression-free survival. And the best patients, whether they have upfront surgery on the left or interval debulking on the right, is in the R0. So in the R0 subset, you can see on the left, primary debulking, R0, complete resection, that many of those patients could even be cured. So I think we need to do both. We need to give the right chemotherapy, we need to do the right surgery at the right time, and then we need to use the right biomarker to predict that. So that's very exciting. And then finally, as you sort of think through this, you come to the conclusion that there are two options for the BRCA mutated patient. You can do SOLO-1 alone, or you can do PALA, olaparib, and bevacizumab together. So this is a very sophisticated manuscript at the SGO. It was also redone at the SGO meeting, sort of asking this question that, what's the role of bevacizumab in the BRCA mutated patient, and are they better treated with SOLO-1 or PALA-1? And you really sort of have to do a meta-analysis to sort that out. So we have bevacizumab versus placebo, but we didn't call that out in GOG 218. We don't have olaparib monotherapy versus bevacizumab monotherapy, the second bullet point lower down. Olaparib plus bevacizumab versus olaparib, well, that certainly is the PALA-1 opportunity, but we don't have PALA-1, olaparib, bevacizumab versus placebo. So how do we figure that out? We'll never do those studies. So I get it that cross-trial comparisons are difficult. I don't want to do a cross-trial comparison. I want to use the intellect that we have and the best statisticians sort of to harmonize those together to make good decisions. So I've already shown this to you. I just want to refresh your memory. And this is very innovative, is to do this unanchored population-adjusted indirect comparison using patient data and only in the BRCA mutated group. So again, the question is, if a patient has a BRCA mutation, do they get olaparib alone, SOLO-1, or do they get olaparib, bevacizumab, a la PALA-1? And so they matched these sort of subsets and took these patients and tried to create a weighted Cox regression and Kaplan-Meier. So what they do is they take patients and they reweight them to balance the key baseline characteristics. So I get it. It's not a cross-trial comparison. We're trying to do better than that. I get it. It's hypothesis generating, but this is what you and I want to do. And I was really moved by this sort of opportunity. So they do that, and they re-weight even in the PALA-1 BRCA subset. So let me give you an example. So these are the pre-adjusted subsets, and you can see that just look at stage 4 in PALA-1 BRCA group, that was 29%, and in 29 patients, but in SOLO-1 it was 16. They weren't balanced. So you can't really do cross-trial comparisons of the BRCA mutated cohort in PALA-1 and the BRCA mutated cohort in SOLO-1. But you can go ahead, and same with residual disease, but you can go ahead and do some adjusting where now there are groups, and they could do this through working with the sponsor because they had the data sets. See, generally you can't do this because one sponsor owns one data set and the other sponsor owns another data set. But because both of these studies were academic trials, and because the sponsor was willing, they could do this sophisticated analysis, which has never before been done before. So here's the first, bevacizumab versus placebo. This is basically GOG 218, but in the BRCA cohort. And remember, in GOG 218, the hazard ratio is 0.62. We've never thought that BRCA made bevacizumab work less, and this sort of suggests that. Hazard ratio 0.65, the difference is about 6 months. So in the BRCA mutated subset, bevacizumab still has an impact, and this supports what you would think. So here is olaparib monotherapy versus bevacizumab monotherapy. We've never done this. But with this adjusted weighting, you could do that. And there's no surprise that, and you would already come to this conclusion on your own, that olaparib is better than bevacizumab in the mutated subset, patients with mutated tumors. Quite a bit better, right? With a hazard ratio of 0.48. So that again follows sort of the supposition. Now here is olaparib plus bevacizumab versus olaparib. And this is really the key question, right? Do you want olaparib plus bevacizumab in the BRCA mutated subset, which is PALA-1, or do you want olaparib alone, which is SOLO-1? Both are FDA approved, and you have to make a decision. And here's the difference. The difference is a hazard ratio of 0.71. You can see that even in BRCA mutated tumors, that bevacizumab adds to the PARP inhibitor alone in this sort of analysis that I think is very sophisticated. So I think the answer is that the preferred regimen in a patient who has a tumor BRCA mutation, which could either be germline or somatic, is the combination, which is really impactful and practice changing. And that's why I'm very grateful that you would get on this sort of a recording and let me share that with you. And then here is olaparib versus placebo. So olaparib bevacizumab versus placebo. Again, we didn't do that. But the worst answer, the worst choice in a BRCA mutated tumor is placebo. And you can really see the dramatic 36% or progression-free at 2 years versus almost all 82% at 2 years. So don't fall into that trap. And I think I showed you that bevacizumab still works in BRCA mutated tumors, and that olaparib a la SOLO-1 is good. But olaparib bevacizumab a la PALA-1 is better. And that makes sense. So what's next? So again, Imagine 50 is next. We're really interested particularly in the HRP subset, the patients that don't have HRD. We know that bevacizumab works in that subset, of course, but maybe we can add a checkpoint inhibitor, in this case, atezolizumab. This is a GOG study, GOG 3015. I'm very passionate about this. Katie Moore, the same first author of SOLO-1, is the PI of this as well. She's very ambitious. And this trial will report this year in 2020. So in 2018, we had GOG 218 in SOLO-1. Okay. 2020, we had FDA approval of PRIMA and PALA. And this will report this year in 2020 and probably lead to FDA approval in 2021 if positive. So how do I synthesize all this? Okay. So when you see a newly diagnosed advanced ovarian cancer patient, The first thing is there's no question that she needs intravenous, not intraperitoneal, every 3-week chemotherapy, not dose dense weekly. I mean, I didn't show you the data, but that's been proven many times. But you have to make a decision in the beginning. Is this patient a candidate for neoadjuvant chemotherapy or primary debulking? Remember, primary debulking is the best, assuming she's strong enough and you can get the tumor out and she doesn't have a complication so that you can start chemotherapy on time. Let me say it a different way. That if the patient has a serious complication, in other words, you can't get away with it, she's too infirm, and she doesn't recover quickly so you can get started on chemotherapy, I get it, it's in retrospect, but it was a bad idea. And certainly if you can't get the tumor out, ideally R0 or really small volume residual disease. So you have to, that's the hardest decision we make. If you need to stick the laparoscope in there to figure that out, that's fine. And then you have to make a decision, bevacizumab, yes, no. Clearly the high risk subsets, the stage 4 patients are ideal. It still prolongs progression even in the small volume residual disease. And then based on that second decision point, you have to make a third decision. And this is as per the NCCN guidelines that were updated March 11th. So if there is bevacizumab on the bottom, I just showed you this analysis that the BRCA mutated or the HRD, same thing, it's not the same thing, but there's an overlap, should get a PARP inhibitor, okay? If they're HRP, then they should continue the bevacizumab. And I show on the right the suggestion or the studies that supported that conclusion. There's no bevacizumab, and she has HRD or a BRCA mutation. The results are very similar. Then they need a PARP inhibitor, either olaparib ala-SOLA1 or niraparib ala-PRIMA. And if they're HRP, then they should get PRIMA. This is the most, or niraparib, this is the most controversial, but many of us want every patient to get a PARP inhibitor and bevacizumab at some point in their history. And this may be the only place, the only opportunity where an HRP patient can get it. Because if she doesn't get niraparib in the HRP subset, it's unlikely that she's going to get a platinum-sensitive relapse and unlikely that she's going to have another response. It's true she might get sort of a NOVA study 19 aerial 3 opportunity in recurrent maintenance, but it's unlikely, so this may be her only opportunity. So I appreciate you spending time with me today. We have 4 indications in frontline newly diagnosed advanced ovarian cancer, GOG 218, bevacizumab alone, olaparib, SOLA1 in BRCA mutated patients, and then PRIMA in all comers with a big effect in HRD, and then PALA1, combination bevacizumab and olaparib in HRD positive patients, making that the preferred regimen, not only for HRD, but for BRCA mutated patients. So thank you for spending time. Hopefully you found this distillation and synthesis helpful, and I hope to speak to you again soon. Thank you.